Good morning. It's my honor and privilege to present to you today. Um, I'm going to be talking about why cooling is always cool. And lots of respect to Matt Suba, but here we go. So here are my disclosures. While I do have some financial disclosures, none of them correlate directly to what I'm going to present today. But my main disclosures are right here. So this is how my brain works. I'm always thinking about time is brain, doing the right thing. And I know that doing the right thing is not always going to be the easier thing to do. For me, resuscitation and recovery are part of the same continuum. Whenever we don't have reliable markers or measures of what we really want to measure, we've got to use reliable surrogate markers. When providing care, we've always got to reevaluate how we provide care in light of new evidence in the spirit of lifelong learning. But that does not mean we've got to abandon good practices. We've got to adapt. We've got to be consistent. Always providing care in line with someone's goals, values, and wishes. And of course, it's teamwork that's going to make the dream work. And the patient, their family, are as much a part of this team as anybody else on the team. So now let's share the neurocritical care framework with you. So there's the primary neurological injury that has already occurred. Secondary neurological injury needs to be prevented and can be treated rapidly. Systemic injuries are going to contribute to secondary neurological injuries, and we monitor and prevent these while our patients are admitted in an ICU setting. All of this while rapidly diagnosing and treating the primary neurological injury because time is brain. Why does this all matter? This matters because it is that cumulative injury burden from the primary neurological injury and the secondary neurological injury that is going to impact the overall neuroprognostication for our patients. It's really going to help us optimize patient-centered outcomes in every single domain, right from the physical domain, cognitive domain, mental health domain, return to work, what is meaningful to our patients, and then really preparing our patients and families for that new state of normal. And this framework can be applied to any neurological injury. In terms of monitoring strategies, why is it so important to monitor? Of course, we want to rapidly diagnose and treat the primary neurological injury, rapidly diagnose and treat secondary neurological injuries, but prevention becomes even more important for secondary neurological injuries. So there are lots of different ways. We know critical care environments are data-rich environments. We have lots of different tools at our disposal. And things can become very complicated if we don't have a consistent framework in how we're going to leverage all these different tools. In terms of monitoring strategies, we could choose to monitor pressure, perfusion, oxygenation, both for the brain as well as for various systemic organs, and temperature, because that's what we're here to talk about. Is cooling always cool? There are lots of different ways, both systemic. So systemically, we've got invasive continuous ways of monitoring temperature. We've got non-invasive ways of monitoring temperature. There are lots of different strategies in which we can do this for the brain. Unfortunately, we don't have a lot of ways of measuring the brain's temperature non-invasively, but invasively, brain temperature probes could be used. And another thing to keep in mind, from neuromonitoring to neuroprognostication, we know neuroprognostication is hard, irrespective of the underlying neurological injury, and one size is not going to fit all. So as we take into account that cumulative burden of injury, guiding patients and families to begin to understand what their new state of normal could look like is extremely hard. And there's a lot of variability, not just because of patient and disease-related factors, but also our own abilities to synthesize this data and measure how recovery is going to happen in different domains. So of course, we want to provide targeted definitive treatments, want to provide excellent supportive care. We've got to adapt and be consistent in how we're delivering our care, irrespective of type of neurological injury. And looking a little bit ahead to the future, as we improve our diagnostics, as we improve our ability to synthesize this data, right from population level data to patient level data, can we really provide personalized care for our patients with different kinds of neurological injuries? So now let's take that concept and apply that to hypoxic ischemic brain injury, or the kind of brain injury that we're seeing in our patients with cardiac arrest. So the primary neurological injury that happens in patients with cardiac arrest is HIBI, or hypoxic ischemic brain injury. These patients are going to remain at risk of developing a whole slew of secondary neurological injuries, right from cerebral edema to infarcts to status epilepticus to complications from their underlying systemic causes, multifactorial. Of course, different types of shock will occur in these patients, shock and different organ systems will fail, impacting not just that organ system, the entire body, as well as the brain. And of course, there's always the risk of iatrogenic harm, medication-related injury. So our cardiac arrest patients are no different as compared to any other patients that I take care of as a neurointensivist in a neuro ICU. The question arises, can we really modulate, prevent, even slow down hypoxic ischemic brain injury? The simple answer is yes. Several things can be done by way of prevention in the peri-arrest period, in the intra-arrest period, in the post-arrest period. We know that this whole cascade, if you just look at one kind of cascade that's propagating secondary neurological injury, it's this inflammatory cascade. And this looks so familiar to other things that happen as part of post cardiac arrest syndrome. The ERC summarizes the approach to post resuscitation care using multimodal approaches at every step of the way. So let's just hone in on post-arrest care. I'm going to give you a little pause. Think of that patient who's in your ICU post-cardiac arrest. And this is what your patient's brain, with any degree, whether it's mild, moderate, severe, unmeasurable hypoxic ischemic brain injury, is going to look like when they develop a fever. Fever is going to lead to endothelial damage, is going to worsen blood-brain barrier disruption that they already have from their underlying HIBI, increases cerebral metabolic demand, calcium influx coming from hyperperfusion, from that no-flow state to that reperfusion state, causing this calcium influx and excitotoxicity with glutamate release, and activation of this inflammatory cascade, which is leading to apoptosis. There's an excitotoxic injury leading to seizures leading to more apoptosis, ischemia, reperfusion, increased cerebral blood flow from that reperfusion, further causing cerebral edema, ICP crisis, so on and so forth. So there's a lot of different things that are happening to our patients' brains when they are recovering from their cardiac arrest. So the beginning of the journey for them in terms of their neurological recovery is only going to start not just post-ROSC, but perhaps everything that's happening to them even intra-arrest. And fever is perhaps one of those few things that we can control. And perhaps fever is one of those few things that is a surrogate marker of a lot of other things, such as the inflammatory cascade or calcium influx or excitotoxicity or increased metabolism, that we really don't have appropriate tools to use for measuring in our patients post-cardiac arrest. But fever is something we can measure. Fever is something we can prevent, and fever is something that we know causes harm to patients with different kinds of brain injuries, particularly patients with hypoxic ischemic brain injury. So as we're thinking through, when we're trying to prognosticate, we want to be as accurate as possible for providing neuroprognostication for different kinds of brain injuries. And HIBI is no different. Can we really predict at time zero who's going to develop mild to moderate versus who's going to have severe brain injury with or without neuromonitoring? Think about that for a minute. What kind of monitoring can we then implement based upon our estimate of how somebody is going to do? Using core and continuous temperature measuring strategies, you could use that for all of, irrespective of what you estimate somebody's neurological injury burden is going to be. But here's the caveat: do you really want to be reactive? Is that okay for patients at risk of developing HIBI? Or do we want to be prophylactic? Do we want to adjust our targets based on different neuromonitoring strategies. What should the triggers be? Just last night, I was very lucky to receive this tweet thanks to Matt Suba from the PI of Hyperion, uh, guiding us to both of us to really think about this approach, this specific care that we implement after ICU admission for our patients, depending upon how severe we think their injury is going to be. So you could choose, here's a caveat, we're not talking about no TTM, we're talking about different targets of TTM, depending upon our best estimate of what kind of injury someone's going to suffer from, what kind of neurological injury burden someone's going to suffer from. So of course, lung protective ventilation. You could choose different PaCO2 targets, MAP targets, your TTM, each of these different things. And we won't go into the other targeted therapies that you could modulate, but specifically TTM. The bottom line is fever prevention is important, and you're not going to be able to prevent fever if you're not intentional. So let's talk a little bit about that. So we know that time is brain and neuroprognostication is hard. So if we don't institute aggressive measures of preventing fever, of using and leveraging TTM, then we're doing a disservice to our patients. Because by the time they start developing fevers, I showed you that entire cascade that is already in motion by the time you detect a fever at the surface, or your core temperature measurement. We really can't turn back time. If we choose no TTM, then we may inadvertently cause harm to our patients. We're increasing the burden of secondary neurological injuries and thereby worsening our patients' prognosis. But prevention is in our hands. Prevention of both fever as well as shivering. And prevention is easier than treatment. So now let's shift gears and think about what TTM means to you. To me, it means any strategy that aims to achieve and maintain a very specific body temperature. And this temperature could vary between 33 to 37.5, but essentially preventing fever. Even the definition of fever varies. But if we think of any body temperature higher than 37.8 or higher, as some of the studies have and including TTM studies have referred to as fever, then TTM could refer to any of these strategies to maintain and achieve this body temperature of 33 to 37.5. But here's a caveat. Not all TTM is created the same. Low quality TTM, and what does that look like versus high quality TTM? The variability is in how TTM is implemented, right from what are you using to measure the body's temperature, the core temperature? Is there a specific target that was chosen? How is it being instituted? Surface devices, intravascular devices, and then what about shivering? And what about shivering control? And the flip side is, this is what high quality TTM could look like. You have a specific target. There's a continuous way of measuring core body temperature, rapid induction, low variability, slow rewarming, making sure that at every step of the way, we're preventing shivering. And if it occurs, we're managing it appropriately and escalating therapies appropriately in a precise manner, in a consistent manner, and really helping with fever control. So these variabilities in TTM, target, duration, depth, implementation, what are you using, that complicates the picture. First, we've got to do no harm. So how do we institute, once we've agreed to go down the pathway of TTM, once we've made the choice to be intentional, how do we prevent shivering? And how do we measure shivering? How do we escalate our therapies? So here's just an example of a bedside shivering assessment tool. Here's an example of what those interventions could look like from the Columbia anti-shivering protocol. Each of these medications, as you can see, there are both pharmacological strategies and non-pharmacological strategies. But the idea is essentially the same. Let's decrease the cerebral metabolic demand for a brain that is already at risk of developing secondary neurological injury, and perhaps we can reduce the burden of primary neurological injury by being intentional in reducing the cerebral metabolic demand, both from fever as well as from shivering. Now let's look at some of these papers, right? The TTM context really matters. I've told you there's all this variability in how TTM can be instituted. And in each of these trials, it's not that we received a lot of granular information about how TTM is instituted, as opposed to animal studies where it's very rigorous. It's the same way in which TTM is being instituted. However, we've also got to be pragmatic. There are practice variabilities. And if we don't include pragmatism in our clinical trials, it becomes so much harder to implement those clinical trials in real world. So having said that, that's the caveat about clinical trials. But nevertheless, when we look at TTM2 versus TTM1, goes almost double the number of patients. But look at the number of people who got bystander CPR as compared to the Harker and Bernard trials, as compared to even the TTM1 trial. So 82% of these patients received bystander CPR. Think about this for a moment. When was the last time the majority of the patients that you took care of after cardiac arrest received bystander CPR? The context, quality really matters. But what probably doesn't matter as much is the choice of temperature. 33, 36, 37, 37.5. I want to point out to you that both TTM1 and TTM2 had TTM both in the intervention as well as control groups. TTM1 was a trial of looking at TTM 33 versus 36, and TTM2 is also a trial of TTM looking at 33 versus TTM 37.5. Just focus for one moment on TTM2 and just look at the differences when we look at what is happening in the US, in US-based studies versus a predominantly European study. So our systems of care matter. Twice the rate of bystander CPR, twice the number of witness arrests, and even survival to hospital discharge is much higher. And this is the study that really gave us pause and made us reevaluate whether we're doing the right thing by cooling our patients. So this is truly TTM versus TTM. And here's a important question: should we abandon TTM altogether? So I'm grateful to Dr. Sachin Agarwal from Columbia for sharing some of his slides with me. And as a cardiac arrest researcher, this is what he thinks. And I agree. For those in favor of abandoning TTM, they could say TTM2, largest cohort, great statistical methodology, well-conducted study, European populations, strict prognostication rules, and general management overall has improved. So why bother with TTM? But here's what I would like to draw your attention to. TTM2 is applicable only in the settings that it was performed in. I already showed you that there are lots of variabilities in care and care settings, US versus Europe, particularly with respect to bystander CPR. Not applicable to in-hospital cardiac arrest, not applicable to non-shockable rhythms. And here's the most important thing: 46% of patients in the normothermia group also required a device to maintain their temperature less than 37.8. And avoidance of fever for 72 hours was very much part of both the intervention as well as control groups. And controlled rewarming is important. So abandoning any temperature control protocol is not prudent. And here's some more data from real life studies. 33 versus 36 really doesn't matter. From medical science to educational efficiencies to local implementation to improving our survival curve. Looking at the FOG behavioral model, and I'm sure several of you have seen this, what is the activation threshold to reach your target behavior as compared to the motivation? So when something is easy to do, the activation threshold is low, but there's low motivation, we don't achieve target behavior. If something is hard to do, but motivation is high, we will achieve target behavior. With TTM is not easy to do. TTM requires high motivation. And the implementation aspects of how we translate our evidence into practice requires educational efficiencies and dissemination, access to resources and systems of care. Let me show you how we are flawed in implementing evidence-based protocols, even for TTM. We know this. This holds true for low tidal volumes. This holds true for glycemic control, for sepsis, septic shock. This holds true for translating evidence from clinical trials into clinical practice for so many things in critical care that we have to acknowledge we are flawed in implementing evidence-based practices. Only a third of the eligible patients receive TTM across 189 hospitals with over 8,000 survivors. After the publication, when you look at the decrease in the utilization of TTM after the publication of the TTM1 trial, the other thing that we've also known about TTM utilization, there's lots of variability in how different hospitals use TTM. From this large cohort that included the resuscitation outcome consortium sites, you can see how much variability there is even between different hospitals over the same time period from 2013 to 2015. So we know that translating evidence into practice is very hard. There's lots of variability, and that impacts outcomes. In this US registry that included more than 45,000 patients, just look at what happened to the utilization of TTM. And this was related to the publication of the TTM1 trial in some ways, but was also inadvertently associated with decrease in survival after cardiac arrest. So after years of gain in improving cardiac arrest survival, we saw a decrease in cardiac arrest survival. Was that all related to the abandonment of TTM? Difficult to say. And here's another experience from the ANZIC Society with over 16,000 patients. When comparing the 3 years before and after the TTM1 trial, utilization of TTM dropped from almost 46% to 24.6%. Post-resuscitation fever increased, and post-resuscitation mortality, no surprises, also increased. I've highlighted to you that there are lots of problems in variabilities in care delivery and our systems of care approach. Translating evidence into practice is hard. Maintaining a high efficiency of that translation is even harder. Adapting new systems in light of new evidence takes a while and can lead to potentially inadvertently worse patient outcomes. Leveraging our systems of care throughout prevention to recovery is extremely important for cardiac arrest, as well as other kinds of brain injuries. But we just can't seem to translate our evidence into consistent practice. And I think it's not just about translating it into practice, but consistent practice. Here's another caveat to keep in mind. There is improved outcomes in sicker patients with TTM. Here are just a couple of studies. This is from our Japanese group that's looking at outcomes post cardiac arrest, looking at patients who had different levels of lactate post cardiac arrest and mild, moderate, severe lactate levels and the probability of having a 30-day outcome. And you can see that patients who underwent TTM, who had higher lactates, their overall chance of having better outcomes was higher. Here's another study from Clifton Calloway that looks at how the initial severity of critical illness may modulate the response to TTM and to depth of TTM. Their conclusion was choosing TTM at 33 was associated with better outcomes than TTM at 36 for patients with severe post-cardiac arrest illness. But TTM at 36 was associated with better outcomes in patients who have mild to moderate severity illness. So we've got to be able to measure the severity of illness at the time of instituting TTM, change our therapies, change our target based on the patients that we're seeing in this study. They used cerebral edema, malignant EEG patterns to risk stratify patients to understand the burden of neurological injury. So we've got to have better tools. One size is not going to fit all, and let's customize our targets. But that does not mean that we do away with TTM, just choose the right target. So TTM really means being very intentional. in how we're going to institute high quality TTM, early initiation, during the cooling phase, the different methods that we use, minimizing variability, high precision, shivering management. So a lot of these different things really need to be paid attention to. So TTM really means being intentional. So let me summarize this for you. We know that fever is a surrogate marker of a lot of different kinds of brain injuries that we're not able to measure otherwise. We know that hypoxic ischemic brain injury and secondary neurological injuries will worsen with fever. TTM is a surrogate marker of how we are paying attention and being intentional in how we deliver care for our patients, and perhaps is only one of the only neuroprotective strategies we have currently. Fever and shivering both can drive secondary neurological injury, so we've got to strike a balanced approach. Adapt. If there's too much shivering, change your target, but meet that target. Prevent shivering, prevent fever. And changing practice means identifying barriers and facilitators of TTM, not abandoning TTM, but identify barriers and facilitators of TTM to prevent primary and secondary neurological injuries in patients with cardiac arrest. We've got to be intentional in preventing this undoing of all the gains that we have made in mortality benefits, in improving functional outcomes for our patients. We cannot afford to misinterpret emerging evidence. Prevention is better than treatment, and one size is not going to fit all, but TTM matters. So being cool is always cool. With that, I'd like to stop and I look forward to the Q&A. To our patients and families, this is exactly why we do what we do. Thank you.